On behalf of Allergy and Asthma Network, it is my pleasure to welcome you to the December edition of our 2017 webinar series, Advances in Allergy and Asthma. My name is Tanya Winders, and I am the network's president and CEO. We appreciate you taking time out of your schedule today to be with us. Our webinars are tied to our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. The goal of our webinar series, which is also brought to you by the American College of Allergy, Asthma, and Immunology, is to share guidelines-based information and resources with you that are relevant to your life and your practice. Today's topic is chronic urticaria. We'll be looking at medications and management. We are excited to be joined by Dr. Maeve O'Connor. Dr. O'Connor provides a more progressive approach for treating allergy, asthma, and immunology patients. She is board certified by both the American Board of Internal Medicine and the American Board of Allergy and Immunology. She is one of only 3 specialists to have completed the University of Arizona Fellowship of Integrative Medicine, and has been selected by her peers to be included in the Best Doctors of America database from 2011 to currently. Dr. O'Connor has been one of Charlotte Magazine's top doctors for both adult allergy immunology and pediatric allergy immunology from 2007 until the current day. Additionally, Dr. O'Connor is listed as North Carolina's Best Doctors, and she treats patients of all ages and is also fluent in Spanish. Dr. O'Connor is the only board-certified allergist in the region to offer sublingual immunotherapy and is also performing clinical research in her practice. She has published research articles on desensitization immunotherapy, asthma, and food allergy. She is currently involved in clinical research of asthma, allergic rhinitis, immune deficiency, and novel treatment for atopic disease. Dr. O'Connor lectures extensively on all subjects involving allergy immunology locally, nationally, and internationally. She is a fellow of the American College of Asthma, Allergy, and Immunology, where she currently serves on the Board of Regents and has just recently been the Secretary of the House of Delegates. Dr. O'Connor, thank you for being here with us today, and I'll turn it over to you for the presentation.
Thank you, Tanya. Thank you all for being on the webinar. Our learning objectives today are following this session, there we go. Following this session, the attendees should be able to describe the characteristic appearance, etiologies, and pathophysiology of chronic urticaria, as well as formulate appropriate action plan for patients resistant to initial antihistamine therapy based on current guidelines. So there are several categories of urticaria: acute, chronic, physical urticaria, and diseases with urticarial lesions. Here are some pictures showing some example of urticaria. Urticaria is actually an umbrella term which is inclusive of diverse clinical entities. Urticaria, of course, is the medical term for hives. 10 to 20% of the population experience one episode in their lifetime of hives. 0.1% of those will develop chronic idiopathic urticaria. The classification of urticaria is based on the duration, with acute urticaria being defined as lasting for less than 6 weeks. The cause is identified in acute urticaria in 15 to 20% of patients, and greater than 90% have a chance of remission. Chronic urticaria is urticaria that lasts for 6 weeks or longer. The cause in this case is identified in only less than 5% of cases. Less than 50% achieve remission. Inducing factors also are involved with classification of urticaria, the presence or absence of inducing factors. So we have spontaneous or chronic spontaneous urticaria, CSU, and then induced or chronic inducible urticaria, CINDU. Chronic urticaria are pruritic, evanescent, erythematous papules and plaques of more than 6 weeks duration, as I mentioned. They occur almost daily, with the lesions lasting from a few hours to even up to 36 hours. Most urticarial lesions have fairly distinct borders with a perilesional pallor, which represents vasoconstriction, whereas some of the lesions have central clearing. They vary in sizes from less than 1 centimeter to involving a whole anatomical region, such as an arm, a leg, or the abdominal wall. So the features of chronic urticaria, this is the prevalence. In the general population, it's 0.5 to 5%. 40 to 50% of patients have urticaria coupled with angioedema or swelling episodes. 50 to 60% of patients have urticaria alone, and 10% of patients have angioedema alone. But up to 40% of patients with chronic idiopathic urticaria lasting longer than 6 months still have urticaria 10 years later. 40 to 50% of patients have autoantibody-associated urticaria, and 10 to 20% are aspirin intolerant. 10% of these patients also complain of systemic features that go along with the outbreak of the hives. The presence of angioedema in the percentage of patients suffering from chronic urticaria can be associated with increased disease severity, prolonged duration of the disease, and also a reduced quality of life. Angioedema is swelling with no distinct border and may be more painful than itchy and may persist longer than urticaria or hives. Although mucous membranes, lip, and tongue swelling may occur, they do not extend to the larynx, which is a helpful differentiation from life-threatening allergic reaction or anaphylaxis. Now, physical urticaria or hives tend to have a longer duration than chronic idiopathic urticaria. And when I say longer duration, I mean years, not months or weeks. Chronic idiopathic urticaria with concomitant physical urticaria or angioedema may be less responsive to conventional therapies such as antihistamines. And up to 40% of chronic urticaria patients have what's called physical urticarias. This can be dermatographism or delayed pressure urticaria. The true prevalence is difficult to precisely determine. Chronic urticaria can be associated with physical urticarias. The most common is dermatographism, which is reported in 2.5% of the general population. Cholinergic urticaria accounts for about 5% of all cases of chronic urticaria and about 30% of all cases of physical urticaria. Cold urticaria has a prevalence of about 2%, whereas solar urticaria is even rarer, with a prevalence of about 0.4%. Vibratory angioedema and aquagenic urticaria are rare, although they do exist, and I have seen cases of these. Dermatographia, also known as dermographism manifestation, is a rapid onset of a wheal and flare reaction after skin pressure. There are symptomatic and asymptomatic variants. The asymptomatic or non-pruritic, non-itching, simple dermatographism variant tends to be milder, where urticaria can occur at 6 to 7 minutes after pressure and fade sooner by about 15 to 30 minutes. On the other hand, in symptomatic or pruritic dermatographism, the hives can appear in less than 5 minutes after propagation or pressure is applied and may last for longer than 30 minutes. Symptomatic dermatographism is mostly idiopathic, but occasionally there have been some case reports that symptomatic dermatographism has been associated with bacterial, fungal, or even scabies infection, and even after treatment with drugs such as penicillin or famotidine. And there's a picture, an example of dermatographia there. So how do we diagnose it? The simplest office-based test for dermatographia is stroking the skin with a firm object. We usually use a tongue blade, and then we observe the white line or reflex vasoconstriction, which is followed by a linear wheal flare response. The use of a dermatographometer, this is used as a reproducible amount of pressure, which can identify the threshold for the wheal flare response to show up within 1 to 3 minutes. In simple dermatographism, it is usually a higher threshold of 4,900 grams per centimeter, whereas in symptomatic dermatographism, the threshold is lower at about 2,600 to 3,200 grams per centimeter. The treatment of symptomatic dermatographia includes avoidance, skin hydration, and emollients to decrease skin itching, antihistamines, both first and second generation, to which they are very responsive to, and then H2 antagonists plus H1 antagonists, as well as UVB light therapy. Now we're going to move and talk about cholinergic urticaria. Cholinergic urticaria manifests as pinpoint hives. They're usually around 1 to 3 millimeters, and they're surrounded by large red flares. The majority of patients have limited mild symptoms, but systemic symptoms such as bronchospasm and hypotension have been reported. So wheezing and loss of blood pressure have been reported. Common provoking factors include hot baths or a hot shower. This has been reported in about 70% of cases. Sweating can also induce cholinergic urticaria in about 62% of cases, and emotional factors such as stress or an extremely acute stressful situation can also cause cholinergic urticaria in about 24% of patients. Tests to confirm the diagnosis include challenges to raise the core body temperature by 0.7 degrees Celsius or higher, and this can be done with exercise or even hot water immersion. The intradermal injection of 0.01 milligrams of methacholine can also induce cholinergic urticaria. The formation of what's called satellite wheals is a positive test, but unfortunately, this is only seen in 1 in 3 patients that actually have cholinergic urticaria, so it is inconsistent. Therefore, it has a poor predictive value. Treatments such as antihistamines and second-generation antihistamines such as Doxepin and danazol in those resistant to antihistamine treatment, and using epinephrine if a patient's symptoms are severe are often recommended for these patients. Cold urticaria. This is another physical urticaria. This manifests as pruritus and swelling, and it's usually confined to the cold exposed area. However, also, as we saw with cholinergic urticaria, systemic reactions with systemic cold exposure can occur. This can include generalized urticaria or hives, headache, shortness of breath, hypotension, loss of blood pressure, and even fatalities from drowning have been reported in cold water. Symptoms are generally maximal after exposed skin is rewarmed, and common activities associated with cold urticaria are outdoor skin exposure to cold, hand swelling when holding cold objects such as a cup full of ice, something that's come out of the freezer, and even lip or pharyngeal symptoms when ingesting cold foods and beverages. Secondary cold urticaria has been associated with systemic diseases such as hepatitis B, hepatitis C, lymphoreticulaire malignancy, connective tissue disease, and infectious mononucleosis. In such cases, determination for the presence of cryoglobulin, cold agglutinin, cryofibrinogens can be helpful. The ice cube test, using a 0 to 4 degree cold stimulus on the volar forearm for 5 minutes with the appearance of a wheal flare, is the best test for proper diagnosis of cold urticaria. The cold stimulation time test, there's a minimum time needed to induce the wheal, and this may confirm a diagnosis as well as response to medications. So if negative after 5 minutes, the cold stimulation test is repeated at 1 minute increments for up to 10 minutes. If positive at 5 minutes, it's repeated at 1 minute decrements. Some investigators do the hand immersion test, where the hand is fully immersed in 10 degrees Celsius water for 5 minutes. This is very effective in diagnosing cold urticaria, but must be done with caution because systemic reactions can occur, as I mentioned earlier. There's also the temp test, and then there's cold stimulation time tests of less than 3 minutes. These patients may be at higher risk for systemic symptoms, as well as laryngeal symptoms, as I mentioned, from cold food or drink. This may be a risk factor that's independent of systemic symptoms. Don't worry, I'm not going to read this entire thing to you, but I just wanted to show you this slide because it gives a very nice summary of the different types of urticaria that we have discussed and the best challenge procedure or test for proper diagnosis, as well as the first line of treatment, which always includes avoidance, a trial of antihistamines, and then the other treatment modalities are listed on the far right side of the slide. I'm going to leave this here for a moment for you to look at in case anybody has questions about it at the end. So we have our dermographism, delayed pressure, cold, cholinergic, solar. We didn't talk much about solar, but this is hives after exposure to specific wavelengths. These patients have a poor response to hydroxyzine. Other treatments that may be effective are chloroquine. Aquagenic, we mentioned, was rare. This is usually diagnosed by a water compress at 35 degrees for 30 minutes. First-line treatment is H1 antihistamines, vibratory, and then exercise-induced. Anyone with exercise-induced physical urticaria angioedema syndromes should also be given an epinephrine autoinjector, as this can progress to anaphylaxis. This is diagnosed using a treadmill test in the office. Some of these patients also have an associated food allergy, and so food allergy testing may be relevant for those patients. So the key, of course, for the proper diagnostic workup for chronic urticaria is history and physical exam. We go back to 101 medical school, where we know that the best way to properly evaluate a patient with a chronic disease such as chronic urticaria is by using our noggins and getting the history from the patients and doing a thorough physical exam. We want to know the onset, the timing of symptoms with any change in medications, any new exposures, frequency, duration, severity, localization of wheals and itching is an important question to ask as well. Is there any association on the symptoms on the time of day, the day of the week? Is there a certain season? Is it associated with the menstrual cycle? Are there any other patterns that the patient or the patient's family has noted with the onset of a new urticarial lesion? And then any known precipitating factors such as exertion, stress, food, medication, or the physical stimuli that we have been discussing. How about occupation and leisure activities? You only get hives when you're at work, only get hives when you're mountain climbing. These kind of questions help us properly diagnose these patients. Is there associated angioedema or any other systemic manifestations such as headache, joint pain, any GI symptoms, or any other systemic symptoms, even feeling dizzy or some more vague symptoms? Does the patient have any known allergies or intolerances, any known infections or systemic illnesses that may be a cause? Is there a family history? Always important to ask a family history for not only urticaria, but atopy or allergic disease in general. How much do the hives or the urticaria impair the patient's quality of life? This is an important question. And I ask this, of course, being integrative medicine minded as well. How have patients responded to previous treatments? You certainly don't want to repeat the treatment if it hasn't worked, but it's also important in delineating the exact type of chronic urticaria, how they have responded. And then, of course, the physical examination will help make sure that it's only urticaria and nothing else is going on systemically. So urticarial vasculitis. The clinician should always try to differentiate chronic urticaria from urticarial vasculitis, since the diagnostic tests, treatment, and prognosis can differ. Urticarial vasculitis lesions are non-blanching wheals that may have a central dark macule that is suggestive of purpura. These lesions are often more painful or burning than pruritic or itchy, and usually last 24 to 48 hours. They may leave a discoloration that gives a kind of sprinkled nutbag appearance. Urticarial vasculitis has been described as a primary condition in patients presenting concurrently with angioedema, ocular inflammation, glomerulonephritis, and obstructive lung disease. So the evaluation of a patient with chronic urticaria should involve consideration of various possible causes. This is a list of all possible causes. Many of these are rare. Again, for chronic urticaria, IgE-mediated reactions, such as a reaction to a food, drug, or other allergen, non-IgE-mediated release of mast cell mediators, such as aspirin or other non-steroidal anti-inflammatory drugs, Chronic infections, these have been reported in the literature and again are possible but rare causes such as viral infection, helminthic parasitic infections, or fungal infections. Also, always want to keep in mind systemic conditions that are possible causes such as cryoglobulinemia, serum sickness, endocrine conditions, thyroid disease, hormones, and other autoimmune and immune complex mediated processes such as lupus, Sjogren's syndrome, dermatomyositis, and neoplasm. Again, I mentioned these as being possible causes, but all of these are very rare. And most cases of chronic urticaria, in fact, do not have an identifiable cause. So the guidelines for the evaluation of chronic urticaria, the majority of members of the Practice Parameters Task Force expressed consensus for the following routine tests in chronic idiopathic urticaria: a complete blood count with differential, an SED rate, liver enzymes, and a TSH. Extensive routine testing for exogenous and rare causes of chronic urticaria or immediate hypersensitivity skin testing for inhalants or foods is not warranted and should. So just as a summary there, consensus recommendations favor performance of limited laboratory testing to confirm or rule out an underlying condition such as infection, autoimmune disease, or endocrine disorder, because as I mentioned, although they can be a possible cause, they are rare. Chronic urticaria signs and symptoms develop when skin mast cells or basophils degranulate and release histamine and many other pro-inflammatory mediators. This detailed diagram outlines the pathogenesis of chronic urticaria nicely and shows the mast cells and the basophils degranulating and all of the pro-inflammatory mediators such as histamine that are released. Up to 50% of chronic urticaria patients and up to 30% of pediatric chronic urticaria patients may have autoantibodies. 30 to 50% of patients have IgG antibody against the alpha subunit of the IgE receptor, and 10% have IgG antibody against the IgE molecule itself. There are others that can also be involved in chronic urticaria patients, and this includes complement, platelet activating factor, PGD2, histamine releasing factors, and altered basophil function and trafficking, as well as altered mast cell function. So again, we mentioned the evidence of autoimmunity in a substantial number of chronic urticaria patients has been reported. This has been reported with anti-thyroid antibodies. These have been reported to be abnormal in 15 to 20% of patients who have chronic idiopathic urticaria. Other evidence is patients who have a positive autologous serum or plasma skin test. And then the basophil histamine release, which activates target basophils. And this tests for the upregulation of the basophil surface marker CD203C. Other evidence is how patients with chronic urticaria displaying positive IgG autoantibody to IgE, as I mentioned. There's more evidence supporting the efficacy of immunomodulating drugs as well. But it is unclear if autoimmune phenomenon or defects in basal signaling contribute to the pathophysiology of chronic urticaria. So is it the autoimmune phenomenon? Is it the defects in the basal signaling? Or perhaps it could be both. So the in vitro basophil histamine release assay is simply a histamine releasing activity assay where the patient who has chronic urticaria, their serum is mixed with basophils from a patient who does not suffer from chronic urticaria, and then the histamine release is measured. This is a good assay, but there are some limitations, including the fact that it's a functional assay. Some donor basophils work better than others. Mast cells and basophils do not always work with the same serum. There's suggestion that there are other histamine releasing factors. And there are still autoantibodies detected in patients who are in remission. So the basophil activation test, as I mentioned, is a good test. It does have some limitations, but it can help to co-assess disease activity, higher disease activity specifically, as was discussed in the following journal articles that are listed here. The basophil activation test can also help diagnose autoimmune urticaria, as was described by Kim and colleagues in 2016. And the basophil activation test, it could also be a marker for responsiveness to cyclosporin A or Omalizumab. And that was also described nicely in the two journal articles by Iqbal and Jaricki and Associates. And those references are there for you if you'd like to find those articles. So autoantibody-associated chronic urticaria that we've been discussing, is there a need to really confirm the diagnosis? Limited testing may be justified for its reassurance value in patients. But as I've mentioned, extensive routine testing is not favorable from a cost-benefit standpoint and really does not lead to improved patient care outcomes. Again, may have a reassurance value. Understanding autoimmune basis may help patients cope and hopefully help avoid unnecessary investigations. But we certainly hope that it'll stop the unnecessary allergy testing that has proven unfruitful in proper diagnosis of the cause of a patient's chronic urticaria. So again, looking at the guidelines for the evaluation of chronic spontaneous urticaria, you're going to assess the disease activity using an urticaria activity score and an angioedema activity score. And these are represented by a score of, on a scale of 0 to 3, looking at the severity as well as the number of wheals in 24 hours, coupled with the pruritic score, whether it's mild, moderate, or intense, and how troublesome that itching is for the patient suffering from chronic urticaria. So it's there, but it's not annoying. It's troublesome. It does or does not interfere with sleep or activities of daily living. And the urticaria activity score numbers that go along or correlate with the mild, moderate, severe are here in this table. 7 to 15 would be described as mild, a score of 16 to 27, moderate, and a score of 28 to 42. Those patients would be described as having severe chronic spontaneous urticaria. Again, looking at the guidelines for the evaluation of chronic spontaneous urticaria, you look at the impact on quality of life and kind of get down into the details of that. There's the Chronic Urticaria Quality of Life Questionnaire and the Angioedema Quality of Life Questionnaire. And these are validated. And as you can see, the Urticaria Control Test, Weller and Associates described this in 2014 with the following 4 questions. A little bit difficult to read. Physical symptoms, how quality of life, has the treatment worked, do you feel like you're under control? And a score of 12 or higher deems the patient as being well controlled with their chronic urticaria. 1 to 6, well controlled, 0, itch and hive free. And there's even an app for that. So treatment approaches for chronic idiopathic urticaria, of course, our aim in these patients, as in all of our patients, is to try to get symptoms under complete control. When mast cells are triggered in chronic urticaria, they degranulate and release histamine and other mediators such as heparin, tryptase, PGD2, LTC4, and platelet activating factor. Antihistamines can block the effects of already released histamine on the blood vessels. Medications can also block the release of histamine and other mediators, modulate inflammatory, cellular, and other immunologic components, and even block mediators other than histamine. So H1 antihistamines are first-line therapy for chronic urticaria, but unfortunately, they're unsatisfactory in 5 to 50% of patients with chronic urticaria. So the question is, first or second generation antihistamine. And the consensus is second generation antihistamine. The rationale for that is that first generation antihistamines have some side effects that aren't so great, such as sedation and anticholinergic effects, which can lead to dry mouth as well as difficulty urinating. Second generation agents are efficacious, they're better tolerated, and they even have a longer duration of action, so patients aren't having to take medication multiple times per day. So then a question, H1 antihistamines, should these be used regularly or only as needed when hives appear? And the consensus is that they should be used regularly. And the rationale for this is that in clinical trials, this has been shown to be effective. In how to prescribe antihistamines for chronic idiopathic urticaria, there was a study comparing desloratadine daily versus as needed, and quality of life was an outcome. Regularly was superior. Can on-demand non-sedating antihistamines improve urticaria symptoms? Again, the regular use of H1 antihistamines was found to be superior. The mechanism of action of H1 antihistamines, these are inverse agonists with preferential affinity for the inactive state of the H1 receptor. They stabilize it in this conformation, shifting the equilibrium towards the inactive state. That's how they work to control the symptoms in patients with chronic urticaria. Again, talking about the H1 antihistamines, second generation H1 blockers. Should we use these in higher than recommended doses? Consensus, looking again at review of the literature and several clinical trials. Consensus is second generation H1 antihistamines can be used in doses up to 4 times the recommended or approved dose. And many studies have shown benefit of higher dose of cetirizine, desloratadine, ebastine, fexofenadine, as well as levocetirizine. So what about using the second generation antihistamines in higher than 4 times the recommended dose? So if we went 4 times higher, is more than that even better for these patients who are suffering with chronic urticaria? And the consensus is this is not actually recommended. There is no evidence of any further improvement, and it may delay the institution of using a next line of therapy that may end a patient's suffering. H2 antihistamines, not effective alone, add on to H1. That's the question here. Do we do this? And the consensus from the panel, again, not recommended. And the rationale there was there's conflicting evidence on whether or not this is truly effective. There was 2 nice articles from the Clinical of Allergy as well as the British Journal of Dermatology that did show superior efficacy by doing this. However, there was another one published that showed no advantage. So there's definitely conflicting evidence on this, so it is not recommended. Not to mention there are drug-drug interactions that we must be mindful of, including a very dangerous one between hydroxyzine and cimetidine. Omalizumab. For chronic urticaria unresponsive to up to 4 times the dose of second generation antihistamines. Is this recommended? And it is, as third-line therapy. The rationale has been effective and safe in chronic spontaneous urticaria. It's also been reported effective in chronic inducible urticaria, and that would include the cholinergic, cold, solar, heat, delayed pressure, and symptomatic dermographism that we went into detail about earlier. Also shown to prevent angioedema development. It's suitable for long-term treatment. And it effectively treats relapse even after it has been discontinued. So a summary of the efficacy and safety of omalizumab for chronic urticaria, it improved primary and secondary endpoints in a consistent dose-dependent fashion. 300 milligrams improved all endpoints in studies. 150 milligrams improved all endpoints except angioedema. And a dose of 75 milligrams did not meet the primary endpoint. Of note, there was a rapid onset of effect within 1 week of 300 milligram dose. However, symptom scores increased towards placebo after week 12 when omalizumab was discontinued. No new safety issues were identified compared to the known safety profile in the allergic asthma patients who have been receiving omalizumab for years. So, on the basis of this evidence, omalizumab should be contrast to other alternative agents for refractory chronic urticaria. The therapeutic utility of omalizumab has been supported by findings from large double-blind randomized controlled trials. Dosing is independent of total serum IgE when omalizumab is used for chronic urticaria, and there's no correlation of pretreatment total IgE as far as responsiveness to omalizumab or time that it takes for a patient with chronic urticaria to respond to omalizumab. 15 out of 44 study patients, or 34%, sustained remission after at least 52 weeks of treatment, whereas 29 experienced a relapse. Total IgE levels of greater than 100 IUs per ml are linked to faster relapse in omalizumab discontinued CSU. The time to response and time to relapse after discontinuation did not correlate with each other in studies. IgE levels before omalizumab might help to predict and avoid a quick relapse in patients who want to check the need to continue omalizumab. What about Doxepin? So this is another treatment that has been used for chronic urticaria. And it is a tricyclic antidepressant, but it is 775 times more potent as an antihistamine compared to diphenhydramine at a dose of 10 to 50 milligrams per day. So although it's a tricyclic antidepressant, 775 times more potent as an antihistamine compared to diphenhydramine. It blocks both H1 and H2 receptors. It peaks at 2 to 4 hours and lasts longer with a half-life of nearly 17 hours. It is effective and has been shown to be effective for the treatment of acute, chronic, and cold urticaria. Leukotriene modifiers are available as montelukast, deferlukast, and Xyluten CR, and these have been used off-label for chronic urticaria. Data suggests that they may be also most effective in aspirin-exacerbated urticaria or angioedema, or physical urticarias or angioedema. Those are the patients who have a positive autologous serum skin test as well. Adverse effects of leukotriene modifiers have to be taken into account: headache, gastrointestinal complaints, substantial safety advantage compared with other alternative agents. With Xyluten, it is suggested monitoring liver function tests, getting a baseline, as well as getting one at the first 3 months and then every 3 months for the first year. And then if no abnormalities are found and the Xyluten is continued, following those periodically after that. There is evidence from observational studies with cyclosporin suggests that it is effective for refractory chronic urticaria, and it is capable of inducing remission from chronic urticaria. However, there are harms, and there's also costs that must be taken into consideration. There are adverse effects from this drug that include hypertension, renal dysfunction, kidney issues, headache, tremor, lipid problems, cancer, and neuropathy. So it's suggested if a patient goes on cyclosporin at a dose of 2.5 to 5 milligrams per kilograms per day, that they are monitored. So we have the baseline blood pressure, kidney function, electrolytes, lipoproteins, and liver function tests. And then to follow up with these monthly for 3 months, and then periodically after that. In some patients, they also may need to have this blood checked, the drug level, about every 3 weeks. So it does have good effectiveness in severe cases, but there are lots of things to consider with cyclosporin. Corticosteroids. These are frequently used for refractory chronic urticaria, but there are no controlled studies that have demonstrated efficacy. Short-term use, like 1 to 3 weeks, may help control chronic urticaria, and this is suggested until other therapies can achieve control. Again, there are adverse effects. Every action has a reaction, and these are variable. Some patients experience mood alteration. Some patients gain weight, whether it's adipose or fluid, hypertension, hyperglycemia, osteopenia. Some patients develop cataracts. Intraocular pressure increases have been noted. Some patients complain of headache, infections, atrophy of the skin, and GI complaints, which can vary from cramping, diarrhea, nausea. You want to be careful using corticosteroids in children and any patients who have a pre-existing psychiatric disorder and patients with diabetes. So numerous other therapies have been used for the treatment of refractory chronic urticaria. This table lists the more commonly reported therapies, their adverse effects, and the recommended monitoring for the use of these drugs. Anti-inflammatory agents, including dapsone, sulfasalazine, hydroxychloroquine, mycophenolate, and colchicine, have limited evidence for efficacy in chronic urticaria. As you can see here, the information on the drug, what needs to be monitored, and the adverse effects. In the interest of time, I'm going to move on so we do have some time for questions. What about CSU treatment in pregnancy? Second generation H1 antihistamines, there have been no birth defects reported to date with the use of these in pregnant patients with CSU. Preferably choose loratadine, could be extrapolated to desloratadine, and cetirizine, which could also then be extrapolated to levocetirizine. Small sample size study for cetirizine and one large meta-analysis for loratadine. No safety studies have been done with increasing the dosage of the second generation antihistamines, so that's the data there. All H1 antihistamines are excreted in breast milk in low concentrations. So there have been reports of infant sedation in patients who have been exposed to first generation antihistamines. It has been shown to be transmitted in the breast milk. That's the cause of that side effect. So therefore, these should be avoided. Omalizumab, there's been no indication of teratogenicity. Cyclosporin itself is not teratogenic, but it is embryotoxic in animal models. Cyclosporin has been also associated with preterm delivery and low birth weight in human infants. So here's a nice algorithmic approach to the patient with chronic urticaria or angioedema. So patient shows up with a history suggestive of chronic urticaria or angioedema, and they say, well, actually, I don't really get hives. I just have swelling episodes only. If you look to the left of this algorithm, those patients, we may consider medications as a cause of the angioedema or one of the C1 inhibitor syndromes as a cause of the angioedema. If the patient has chronic urticaria as well as angioedema, then that's where that history and physical exam are really the first thing you want to do to properly diagnose. So is the history and physical consistent with chronic urticaria? Yes, then you would go down that treatment path. No, then you would want to say, okay, let's talk about physical urticarias. Would a physical urticaria be here? Yes, then you would want to do one of those appropriate challenge tests that are nicely outlined in the table from the earlier slide. No, it didn't seem like a physical urticaria. You would want to then think about vasculitis. If you're considering vasculitis, a biopsy is your next step. If not, then you would want to do the limited blood tests to look for any other underlying systemic cause. Yes, then you would want to treat that condition. No, then manage the chronic urticaria according to the treatments that we have discussed today. And this is a nice stepwise picture of treatment strategy for severe refractory chronic urticaria. This is a nice summary for a disease that can be challenging and frustrating to treat. So number one, of course, avoiding any known triggers, monotherapy with a second generation antihistamine. Step two would be dose advancement, adding a second generation H1 antihistamine up to 4 times the dose, add H2 antihistamine, add a leukotriene modifier, add a first-generation H1 antihistamine at bedtime. Third step, dose advancement, add a potent antihistamine such as a hydroxyzine or Doxepin, keeping side effects and drug interactions in mind, and doing this as tolerated. And finally, looking at the final step, Omalizumab, cyclosporin, or other anti-inflammatory medications, immunosuppressant medications, or biologics. All of these steps, of course, may have to have the addition of short tapering courses of oral corticosteroids for flare-ups, but again, 3 to 7 days, and the data there for long use is not, we don't have it. Percent responders, who responds to the medications that we've been talking about. Antihistamines in higher doses, so again, the 4 times of the dose, usually offers relief in about 40 to 60% of patients. Corticosteroids, 95% of patients may respond. They may require inordinately high doses to reach this level, and probably 60 to 70% response at probably when you only have 15 milligrams. You may need a high dose, but 60 to 70% of patients will usually respond with 15 milligrams. And then cyclosporin, 60 to 70% responder, and Omalizumab, 65 to 75%. Okay. Thank you for your attention. I think we have about 10 minutes for questions. I'm happy to entertain those.
Great, wonderful. Thank you so much, Dr. O'Connor. I have the first question. The first question comes from a school nurse who says, when we have a child who's been diagnosed with cold urticaria, are there recommended temperatures or guidelines for recess protocol?
Yes, so because of cold-induced urticaria, not only can be troublesome and frustrating, but this is the one that can also lead to systemic symptoms. We definitely want to keep our children protected. So certainly if there's any snow, sleet, or freezing rain, any temperatures, of course, that would allow those kind of weather conditions, I would keep the child indoors. If it's a more moderate cool day, temperatures maybe in the 50s or higher, I let the patients go and enjoy recess, but they may have to cover up. Then between 40 and 50, I do it with caution. You know, between freezing and 50, I actually have patients be a little bit cautious, covering up their hands with mittens, making sure they have socks. If everything is the most that you can cover, then you're not going to get the symptoms because it has to be exposed to cold. I don't want patients with cold, especially children, cold-induced urticaria, to not be able to enjoy the normal activities of childhood, such as recess. But certainly when we're getting down into those very cold temperatures, I would keep the patients inside. And if they're not in those freezing, wintry temperatures, I allow them to go outside with proper coverage.
Okay, wonderful, thank you. Next question, how would you recommend one treat swollen lips?
Just swollen lips? I would recommend the treatment, so the treatments that we outlined here today in the webinar is how I would treat those. Typically those symptoms should respond to antihistamines, particularly if it is the kind of angioedema we were discussing today. So we would start, I'm going to go back to the slide if everyone can still see the slides, is that correct?
Yes.
So I just go back to this. Although this is severe refractory chronic urticaria, we would treat the swelling in a similar manner. If it's very severe and bothersome, or if there's something in the patient's life that they really want to get it down fast, then we could use a short course of oral corticosteroids, as we mentioned as well. Some of these patients, if they have repeated episodes, of course, that would not be what we would want to do on a routine basis, but I've certainly done it, and I have one patient who gets isolated lip swelling, and she got married recently, and we use steroids for that, but we don't use it for all of her episodes.
Okay, thank you. Next question. If you diagnose a patient with cold urticaria, do you always send screening labs to rule out secondary causes?
Yes, I do. Short and sweet. I do, just because I don't want to miss one of the things that can be associated with cold urticaria.
Sure. Okay.
And I listed those on that slide, those labs. So I don't know if the participants will have access to these slides. If not,
Yes.
I'm sure they can ask you for a copy of that.
Yes, great question. So we will be sending out a link to the slides in the follow-up email that will go out tomorrow. Next question. Do patients with multiple autoimmune diseases such as type 1, celiac, and hypothyroidism have a higher risk of developing CU?
There's not a cause and effect, as the question is stated. However, I have seen patients who have chronic urticaria, and when we find that it's refractory to the treatments that we've outlined, we may look again in a very limited fashion for some of those diseases. And I have seen several patients who manifest that perhaps they had a smoldering autoimmune disease or a smoldering malignancy or something like that, but it's not a cause and effect. It typically is, as I state, the body trying to tell you something. But again, I just want to caution that doesn't mean go on a fishing expedition for all of these rare causes, although there are many of them.
Okay. Next question. What H2 add-on do you most frequently use and at what dose?
Well, I use several different ones. There was levocetirizine is one that has worked well in my patient population, and it is has a very nice safety profile. It's easy to take even in the pediatric population, and now that it's recently gone over the counter, it's easy for patients to access as it is also inexpensive. Again, I don't like to always choose one thing. So Dr. O'Connor uses that, so we're going to all use that because I just want to remind you that all patients respond to medications differently. Some get a good benefit from one, whereas they don't get a benefit from the other. So the typical pediatric dose is 2.5 milligrams for allergic rhinitis and 5 milligrams for adults. But again, we know from the data that we can increase that up to 4 times in these patients with chronic urticaria. And I think it's important to just note that when we are increasing these medications, that those are non-FDA approved doses, and to discuss that with patients ahead of time, because I often will get calls back from pharmacies and pharmacists who say, you know, this dose is higher than the generally recommended dose. So I like to prepare my patients and their parents and the families that may occur. So sorry to get off the subject there for a moment, but I thought that was an important caveat.
Oh, certainly. Access challenges and issues are always important to our community. So the next question is, in your opinion, do dead sea salts help?
I am not aware of any data around dead sea salts with patients with chronic urticaria. However, putting on my integrative medicine hat for a moment, I will tell you that dead sea salts, especially baths, are very soothing, are very calming, and very comforting. So I don't know, unless the patient had open wounds or sores or had some sort of allergy to dead sea salts, I would not think that there would be any real risk to using them. There just isn't any body of evidence that I am aware of that there's been a placebo-controlled study or anything like that that has been done. But I will tell you that if the patient uses them and gets benefit, feels better, then I would certainly recommend it. That's where the integrative medicine hat kind of had to come in there for a second, because patients sometimes find things that work for them that we don't even know about.
Absolutely, and we appreciate that from you, Dr. O'Connor. Time for one more question. If a vasovagal response causes chronic urticaria to vanish, can that be a positive indication of urticaria vasculitis?
Not to my knowledge, honestly. I have not heard that. So my answer is not to my knowledge. And if there is somebody out there who does know of any connection, I would love to know about it.
Okay. All right. I'm sorry that we didn't have an opportunity to get to the last couple of questions that were posed. We will try to respond to you on an individual basis. Thank you all for listening today. Be sure to register for our January webinar on January 18th at 4 p.m. Eastern, when Dr. Todd Marr will join us to discuss emergency action planning for children with anaphylaxis. Allergy and Asthma Network is offering a new resource to you, a 3 to 5 minute video post of our popular Ask the Allergist series. You can find it on our website under News and Views. Click on Ask the Allergist. Last month's question was on asthma on the job, and there's a new topic each and every month. You can register for this webinar on our website at allergyasthmanetwork.org and look for education in the horizontal navigational bar near the top of the page and scroll to webinars. You can also view our archived webinars on this page of our website. Visit our site for quality guidelines-based resources on allergy and asthma. Also, access important medical information on allergies and asthma from our partners at the American College of Allergy, Asthma, and Immunology. That can be found at allergyandasthmarelief.org. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. For the staff at Allergy and Asthma Network, we wish you a great and healthy day as we work to breathe better together. Thank you and have a great day.